Thank you. Thank you to Sharon and the program committee for inviting me to speak. I hope I don't bore you guys too much here in the next few minutes. The way I like to start this talk is, does this, oh, next, here we go. It's the first, the question I get all the time is, hey, we can do all these great things with fluoro. Why do I even care about doing it under MRI when it can take longer, and Kathy's unhappy with me because she has to run the SATs and Eileen has to do all this metal checking for the patient. So the real reason is it's perfect for our patients, and there's two key aspects. You've heard a lot about radiation exposure. Well, MRI is radiation free, so we can decrease our radiation exposure to our patients. There's a lot of data out there. There's more coming. There's stuff in the lay press. Parents come and talk to us about this. How can we decrease radiation exposure? And when we talk to parents about this, they're really excited about this opportunity to be able to lessen the radiation exposure to their kids. It's also important for us. A study just came out about increased incidence in cancer on the left side of the brain versus the right for interventional cardiologists, and that type of thing is always being discussed. What I find really compelling is the soft tissue visualization you get with MRI. So here's an example of X-ray cardiac catheterization from the 40s, and I would argue we've made a lot of advances, but we're still relying on shadows and pattern recognition and contrast injections. But we're doing increasingly complex interventions. So I'll take credit for this one. This is a radiofrequency perforation of a pulmonary valve. Many of you at your centers do this routinely. If you're really astute, I'm sure I'll hear about this from Matt later, the bottom right corner shows a pericardial drain there. So, I missed, we drained it, patient was fine, but it gets you thinking, like, wouldn't it be great if I could actually see what I want to see? And that's what MRI offers. So the idea is it has exquisite soft tissue visualization. You can actually see what you want to see, and at the same time, you can perform your intervention. Here's a similar example, near interruption coarctation of the aorta. You see the clinical example with X-ray and multiple contrast injections with catheters above and below. And then under MRI, you can just see the anatomy, the aorta, the balloon, the stent. That's in an animal model, but still it explains the point. This is our interventional cardiac MRI facility at Children's National in DC that we built. It has an X-ray system, biplane, it has an MRI, it has doors that separate the two. So the idea is they can run independently, they can function independently. Hospital administrators love that because you can just do your procedures independently. But when we want to, at our place, Tuesdays, some Fridays, we open the doors for these joint procedures. Here's the same facility at the NIH where I also do some time, and this is an example, a sped up movie obviously, of patient transport into the MRI. We do the procedure there, and then the patient gets packaged up and brought back, just to show you how it works. This is the way I divide real-time MRI guided procedures. The top category is how can we do what we do every day but do it better? And the bottom is how can we do new things? Because that's what we're really excited about. I'm going to touch on everything, but I'm going to focus on diagnostic invasive studies and MR intervention, as well as MR guided novel things. So here's MRI cardiac catheterization. It used to be research consent protocol at the NIH for adult patients, but after the first 50, it was deemed safe and conferred an advantage because these patients were being spared radiation. So it's clinical standard. At the NIH, if you have pulmonary hypertension or you need a right heart catheterization, we just do it under MRI. We no longer need research consent if we don't want to. And here you see a balloon filled with some MRI contrast. It's being guided to the different chambers on the right heart. Here's an example of what it looks like in the room. This is Robert Letterman, Toby Rogers. Both of them are here at this meeting and have spoken, and they're doing a right heart catheterization on a pulmonary hypertension patient. I like to say it was a opportunity of independence for me not to have to be there, because that meant I had actually taught them how to do a right heart catheterization. But you can see it looks like a cath lab. There's a hemodynamic recording system. There's a screen that they look at to see where their catheters are going. There's a scrub table, and then they're operating at the groin just like we always do. They have noise-canceling headsets, so they don't hear the loud MRI, and they can talk to each other. There's some challenges with that, but it generally works. The one nice thing is now it's not tethered to the wall, so you can sort of walk around. Here's an example at Children's National Medical Center. This is one of the patients we did a few weeks ago. On the top, you see the catheter, again, being guided into the SVC, and then into the right ventricle, and ultimately into the branch pulmonary arteries. We turn the blood, we turn black or white, and so that way it helps us see the balloon and where it's going, and we can do that interactively. On the bottom, you see me and Elena Grant. She was one of our fellows. She's now in Atlanta doing a 4th-year interventional fellowship. But this is a clinical study. You can see it's a similar setup. We have a rear projector screen that shows us the GE MacLab system, so we know if we've done a balloon, a wedge for the pulmonary artery, or where we are in terms of pressure when we record that. Elena, you're just seeing walking over to drop the SAT off so that Kathy can run it. And we're sort of corroborating that with our phase contrast flow data. Some of you who have MRI experience know that with MRI you can figure out the cardiac output, the shunt, without any SATs. And ideally, we won't have to run any SATs in the future. Just think of your pulmonary hypertension studies where you don't ever have to run a blood gas, and that's sort of the idea. And this is what we're looking at. So the screen was small on the movies, but this is how we're interactively moving the slices in the heart so that we can guide what we're seeing. So it's not just an AP and a lateral with limited camera movement. We can image at any image plane that we want, and we can see whatever we want, and that's how we guide what we're doing. And we have a lot of different things that we've added to the system at the NIH. We have the privilege of working with some really talented PhDs that have helped us do that. We can also speed up the imaging and slow it down when we need to. For example, when we need to go into one branch pulmonary artery or the other, we can speed things up because we need a little bit of better frame rate. A lot of the really senior people are like, oh, it takes so long, why do you want to do this? We've gotten it down. We've gotten the whole thing streamlined down. Here you see the average cath time is 31 minutes, and that's with multiple conditions. And that's the benefit of not having to draw multiple blood samples if you think about your little babies and blood and all that sort of stuff. So there are some advantages, and we're just now getting to experience that because we've reached that critical time where we've done enough of them that we've gotten the workflow down. So that's diagnostic. Moving into intervention, there's a little roadmap at the bottom there. There haven't been that many of them. But there's been some. This is experience from King's College in London where they did balloon pulmonary valvuloplasty in a patient. In Germany, they've done some coarctation work and had some good success. But a lot of that is early, and we're waiting on some devices that are in the pipeline to be able to do more interventions. For example, there are 3 companies working on MRI-compatible guide wires to help us sort of go to the next level, and that's what it's going to take, industry buy-in. Here are some animal procedures that we've done with MRI just to show you what we're talking about. We've done a series of animals. We've published this doing MRI pericardiocentesis. As you know, most of the time you could do it with ultrasound. Some people do it blind. Obviously with x-ray it's helpful, but we were investigating this to see if we could quantify the amount of volume around the heart for the fusion, but also sometimes if you have a really posterior or loculated or some hard to reach place, can you reach it with better soft tissue imaging? Titus Kuhn worked on pulmonary valve stenting. The idea is, can we do an MRI, figure out if a patient needs a melody valve, and then just put it in under MRI eventually? Some people are looking at doing aortic valve, percutaneous aortic valve replacement, again using MRI, so you can see everything in one setting. And this is all animal work. We're investigating fetal cardiac MRI. I think if you see the fetal intervention movies, everybody's working really hard and it's really cool, but the imaging I feel like needs to be better when it's with ultrasound. Maybe MRI, if we can get really good, will give us that opportunity, and that's sort of a 10 to 15 year thing, but we're starting to look at that. Moving to the next category, X-ray fused with MRI. So this is, the idea here is can we work in our familiar environment, the X-ray lab, but take our MRI images and get the areas that we really like and put them on top of our live X-ray. And Elena Grant, one of our fellows I mentioned before, she presented a really nice oral abstract, and I think she's in the oral abstract finals tomorrow, showing our early clinical experience. This is preclinical. We closed some VSDs in pigs using this, and basically the imagers, our MRI technologist said, hey, see this red circle? You need to put your catheter there. And for me, it made it a lot easier. I don't know if you saw the live case from San Diego today. It was really hard for me to figure out where they need to put their coils. You know, they had a really nice CT scan. If they'd put that up on the screen, maybe it would have been more helpful. What we found in our preclinical experience is it decreased the radiation dose significantly. Before we were talking about we need to spare radiation to our patients. We were able to do that using X-ray fused with MRI. This is a case that Elena showed. Maybe some challenging cases it would be really helpful. Here's a left ventricle to right atrium shunt. It's not your typical VSD. The camera angles are a little bit hard to figure out. And as you can see in the upper left, the angiogram isn't perfect, and you have to get a wire across and ultimately a device. So we used the MRI to say, hey, this is where it is. We said, okay, with the MRI, this is the camera angle you need. We just took one picture, it lined up, we crossed, and then we closed. Electrophysiology, I'm not smart enough to be an electrophysiologist, but there's some really cool stuff they're doing out there, and basically it boils down to MRI contrast allows them to see where they need to ablate, help them ablate, and then see where they ablated. We're doing a study that's getting presented at AHA for ventricular tachycardia, which is a hard one to do. You guys probably know more about it than me. And then, you know, it's obviously really bad if it persists. And so what we've been doing is we've been ablating kids with VTAC and then studying them in the magnet to say whether they're likely to recur or not. And the preliminary data is pretty cool. Certainly the pictures to me, which is all I can understand, look cool. And then there is an integrated EP system built for MRI. So you guys, obviously everyone knows things have to be MRI safe. So there's an MRI EP system, and they have done patients in Europe. There was actually just a press release in Leipzig. They just opened a brand new MRI guided EP suite. We've been investigating, can we do cool procedures or novel procedures using MRI, because we think that the soft tissue is really, really great. And some of you at your centers do per ventricular VSD closure. What we looked at is if we made an animal model of muscular VSD, can we close those VSDs using MRI? And you can see the MRI pictures are excellent to sort of delineate that. And then in the next frame, you can see that's us outside. There's no mini incision or anything. It's just me with a needle, and I'm aiming it at that hole. And we can see, again, in any slice, we can see where we need to go. And then once we do that, we enter the right ventricle, cross over with a wire, and then it's just your normal sheath and device. And here you can see the device being deployed to close the muscular VSD. The green signal is a cable. It's like a delivery cable, but it's plugged into the scanner, and then we overlay that signal. And we think that helps. You may not be able to tell here because of the movie quality, but what happens is when the one disc goes out, the signal gets a little different. And then the second disc goes out and it gets a little bit more different. It gets brighter, so that helps us sort of figure out, hey, this is where we are. And then since there's no surgery, we can't suture, but what we did is we just injected some MRI contrast through the sheath, and then we used a vascular closure device just to close the right ventricular free wall. What we found, and someone asked this question in an earlier session, will you trap the pericardium? And so what we did is we filled up the pericardium with some saline, and that separated the walls, and then we were able to push the vascular plug right down on top of the myocardium, and you'll see that sort of we're pushing to get it down there, tamping it down, and then we just drain all the fluid out that we had put in purposefully. So you'll see the angioceal being pushed down in right here. Actually, we pull the foot up against the heart to secure it, and then we push down the collagen plug, and then we drain the fluid. One thing we've been working on is can we do cavopulmonary anastomoses or Glens. People have been talking about this in different sessions here at PICS. I love PICS because you get to hear new things. And this is the idea. With MRI, we can see the SVC, we can see the PA. Can we needle it, wire it, and then put in covered stents? One of the great things about MRI, in any plane you can look at things, and so we've lined everything up and see that big circle in the red square. That's the right pulmonary artery and where we're targeting. And then you'll see the active needle. I'm just showing you in two planes. Again, the green. Green's my favorite color, so that's why it's always green. And then we just puncture the right pulmonary artery. We inject the contrast to prove we're there, and then the wire. And then after we've wired it, what we did is we put in covered stents. These were supplied by Doug Villeneuve, who I learned at this meeting is not with us, and so we really appreciate all he's done for our field, and me in particular, all he's done for lots of the work that we've done. But we implanted covered stents to direct the superior vena cava blood flow into the pulmonary arteries. And then afterward, this is what it looks like by angiography at the top, MRI at the bottom, and then there's a reconstructed CT. So it's a cavopulmonary anastomosis SVC to pulmonary arteries guided by MRI. We are working on a purpose-built device, and then the next movie is just from a recent experience with that. We're working with a company for a self-expanding stent that we can then put in right into the SVC area. Here you see a retention skirt. That way I know I'm not going to miss. I put out basically the rim and then pull it back up against where I need to go. Pull the whole thing out. No balloon necessary. And we pull all the wires out. And then at the very end you'll see us inject some contrast again just to sort of prove that we are where we think we are. Let's see if I can get this. And then the last category, I said I'd touch on everything, is just MRI inspires novel interventions. One of the things that Bill, one of our cardiac cath technologists at the NIH, and I do is we sort of sit there and we study the angiograms of all these experiments. And Bill was like, why can't we get to the mitral valve this way? Or we'll say, hey, look, the pulmonary artery's right there, right next to the right atrial appendage. What if we exited the right atrial appendage to get there? And we come up with these ideas because we're studying the anatomy in ways that we're not really used to. It's not the sort of normal stuff. So we've invented a bunch of different things that we've been sort of pitching and working on. One is cinching the mitral valve with a cerclage type device. We did something similar for the tricuspid valve. We noticed that we could exit the IVC and get into the aorta, and then we could put in big implants, and there's a growing clinical experience putting in aortic valves, exiting the IVC and into the aorta, and then closing it with a muscular VSD device or a PDA device on the way out, and that's in adults. And then Toby Rogers presented this backstabbing concept, which the editor told us to take out of the title for our paper that we published. But basically, it's a way to get to the mitral valve straight from the back. As he showed, it was invented in the 60s, but we think with MRI and better imaging guidance, people will have more of an appetite for something like that. So that's it. In conclusion, we've been working on this for about 10, 12 years, and we're sort of getting to where other sites are very interested in potentially developing this technology and pursuing it for patients. I think we've reached that critical level where people are picking up the phone and calling us and saying, hey, we want to do this. We're having an interventional MRI course where we're teaching it how to do it in patients. We have 8 centers coming, 3 from the US, 5 from Europe, and that's this fall. And at this meeting, a lot of people have been upset with us that they weren't invited, so we're going to do another one in the spring and just do the whole thing again. But for us, that's great. I mean, the NIH mission is to get it out to the rest of the country. That's our job. So hopefully we'll be able to do that. We think that it spares radiation. You can see the imaging a lot better. You can see the soft tissue, and it inspires new things. Thanks. Sorry, just in closing, I get to be the person who gives the talks, but I'm not the brains behind the outfit. I work with a really talented team, and I really appreciate everything they do.